Good evening and welcome to The Square. Tonight we're going to be talking about the quality of healthcare in this country. It's a very broad topic for sure. So some of the things we're going to focus on are based on non-communicable diseases, the quality of human resources in the healthcare system, and also looking at how we can drive medical tourism up in this country with a role from the private sector. My name is Diana Mpisi. I'm part of The Square. I'm always joined by my three resident panelists, Brenna Namata, looking lovely in pink tonight. Welcome to the show.
Thank you for having me.
And Charles, also looking good in pink.
Thank you, Dan. How are you?
Welcome to the show. I'm good. And Ephraim, welcome to the show as well.
Clearly, I didn't get the memo.
Yeah, you didn't get the memo. And tonight we are joined, very, very honored to have him here. Is our guest for tonight. He's called Dr. Emmanuel Rudakemwa, the chairman of the Rwanda Medical and Dental Council. Dr. Emmanuel, thank you for joining us this evening.
Thank you so much, Diana, for the invitation. It's a pleasure being here, and I believe I'll contribute effectively on this important topic.
Thank you very much.
Thank you.
Before we go into this particular topic for this evening, I would like to start off on, a review of the week thus far, and I'll start with you, Charles. What are some of the things, the highlights of this week that you'd like to bring up, as you always do?
Thank you for skipping me.
There was a secret show that didn't happen. So I had whispers of Sauti Sol after they were supposed to have come. And I picked this from their Twitter handle. And they were complaining that they arrived in Kigali and they did not perform. So I think I would consider myself amongst the few socialites that are in town. So one.
Wow, okay.
One, that I didn't know that they were coming is a problem in itself. Two, that they got into Kigali and they did not perform is a worse problem. And I think that's extremely concerning. I remember when we hosted our good friend Pichette and were nailing her on government not being able to effectively do business. This is a perfect example on how certain things should not happen, especially in this era of perfecting our milestones. Yeah. Shame.
Ephraim?
So for me, I find that interesting.
That he's a socialite.
That's I think beyond what you talked about.
Let me emphasize that was for purposes of driving my point home.
But
you are.
For purposes of driving my point home.
For me, it's the Zimbabwean election. And I think what's funny, and I don't know if that video is true.
That's the one that's been circulating.
Yeah.
The bribe.
It looked so curated.
And grainy.
And then also I felt like when Mugabe came out to endorse the opposition, I think in my head it might have been a play by ZANU-PF to discourage people from voting for him. I don't know. I just find it, I can't wait for the results. But at least to see what happens after that. But I just found it very interesting. It was my highlight of the week.
Brenna, your highlights of the week so far?
One, it's the looming trade war. It's very disturbing that we still have a big brother, a big economy going around bullying, the world. More so because this week, President Trump effectively effected what he had said about AGOA for Rwanda, which is a big shame in my view. And it goes to speak to the kind of hostile global environment that we are in, which again should get us to refocus and find ways of getting self-sufficient and reliant.
Dr. Emmanuel, would you like to contribute as well? Your highlights of the week.
That is new to me, but as a person that is in the health sector,
yes,
I think there's been a highlight which has not yet been, I think, put to the media. The government of Rwanda is soon operating. Actually, it opened today. It is most likely that it opened today. We are opening a national cancer center.
Wow.
So which is definitely going to change the gameplay for management of non-communicable diseases, and particularly cancer disease in the country. So that was a huge contribution to the health sector. And actually the system is one of the best systems in the world.
Is it going to be in Butaro?
No. it is going to be in the Rwanda military hospital,
yeah.
not in Butaro.
Soldiers always take the lead.
Oh yes, they should. Yes.
That's good news. So basically, we really want to discuss healthcare in Rwanda, and you're here as someone who's been involved not only as a doctor but also in charge of different bodies that represent the healthcare system. And my first question I'd like to put on the panel is with regards to human resource development. And here I'm talking about two key issues in our healthcare system, producing a high number of doctors, or physicians if you will, as well as producing quality, ensuring that they are well trained and retained. So my question in a nutshell to you is that to this end, government has set a target of 1 physician to 10,000 people ratio before the year 2020. Currently, I think the numbers are 1 doctor or 1 physician to 12,000 people, in a population of slightly over 12 million people. And please correct us if we are wrong. But my question is, you as RMDC chair, do you think we can reach this goal in time, in terms of the objective of reaching this ratio in 2020, which is technically in 2 years from now?
Yes, thank you very much. Looking at the historical perspective of how our medical profession has advanced, if you look back in 1996, we had less than 100 doctors. And probably then we had relatively between 8 and 9 million. We are now close to 12 million or 11.56. When you look at that time and look at how we are today, in 2018, we have got the number of registered medical practitioners close to 1,500. That's a huge boost. We've got close to 400 specialists. That time, we didn't have more than 4 specialists in the country. We've got close to 145 residents. These are postgraduate trainees who are training to become specialists. We have about 9,000 plus, actually, nurses and midwives in practice, and more than 4,200 or 300 of what we call allied health professionals. We include physiotherapists, lab technicians, radiographers, and so many of those people that actually, you know, we work as a team. Sorry?
Anesthesists, are they?
Yes, anesthetic physicians, yes, we do have them. And when you look at the rate at which we've been progressing in terms of human resource capacity development, you really cannot hesitate to say that with 2020, Vision 2020, we are likely to hit this target of 1 physician per 10,000. Because if we are 12 million maximum and we have 1,500 doctors, it's already something big towards that vision. Yes. If I could say something else, yes. You know, having quality and quantity at the same time is a bit paradoxical, because if you look at the historical perspective again of establishment of medical schools on the continent, you realize that for every 15 years, that's when public medical schools have been coming up. That is from around 1960s to date. If you look at Rwanda, we have not put any other public medical school.
Is that deliberate?
That is not deliberate. It could probably be in tandem with the capacity, national capacity. But again, you do not need to put many medical schools without improving the one you have. So I think the concentration has been to improve the existing medical school, which still has challenges, particularly in terms of infrastructure, in terms of equipment, in terms of faculty, the lecturers. So you do not need to multiply the number of medical schools without first improving the first one. What has been put in place, though, is that we have put in place a new dental school. And dental schools in Africa are actually very few, because they are heavily capital intensive in terms of equipment purchase and the faculty. So is it possible that the private sector can come in to support the government or come as public-private partnership? We so far have one private medical school, which has it has got its challenges. We also have some new 2 or 3 medical schools coming up, which are private-oriented. And so we think we are on the positive trajectory, and indeed, we may hit this number even before then. But of course, having a quality, well-qualified medical doctor requires more than wishful thinking. Thank you.
And while on that subject, before I hand over to the panel, you know, we're talking about human resources, and we're talking about physicians plus all the human resources involved, from doctors to nurses to midwives and what have you. The retention of our doctors in public hospitals, let alone in the country, how can we secure that even more? And here I'm talking about brain drain, not only from doctors leaving Rwanda to go abroad, but also doctors leaving public hospitals where they're needed most to go into the private sector. And do you think salary increase is one of the ways that we can deal with this issue?
Thank you for the good question, because actually retention of professionals is not only through financial incentives. If you have got, if say for instance, you are a specialist in radiology or nuclear medicine or radiation oncology, and you don't have that equipment to help you perform what you studied, then you actually have no role to play in the advancement of the sector. So if you have equipment, you have infrastructure, you have colleagues, this multidisciplinary teamwork, it's actually more incentivizing than saying we have increased your salary by 20%. Because when I have a problem and I have nobody else to ask, then it becomes more challenging to me, because it hits at the top of my understanding. Because remember, doctors or healthcare professionals are supposed to be very, very honest people. So once you are not honest with yourself and therefore satisfied with what you're doing, then you'd rather not do anything. So yes, financial incentives are extremely important, because if you look at the region, the salary scale of Rwandan doctors or Rwandan healthcare professionals is relatively low when you compare to Kenya, of course not Uganda, but again, you cannot expect Rwandans to work like Ugandans, because in Uganda there are things that are within their cultural values that you cannot find here. You cannot be a doctor and be expected to moonlight in 5 hospitals, whereas in some of the neighboring countries, that is permissible. So if you want, yes, to promote this healthcare professional, you need to put a development plan. Yes, you have a bachelor's degree. Can this person get a master's degree? And clinical skills oriented. Can this person grow for the, I mean, like in the people in public service get advanced, both vertically and horizontally. Unfortunately, it has been stagnant for the medical professionals or for the healthcare professionals for quite some time. But now it has started being implemented, at least in the leading training hospitals. So if I deserve to be a chief consultant and I become, that may be actually an incentive more than adding 20,000 to my salary. So you're looking at a multifaceted way of incentivizing professionals such that they indeed get retained in both private, I mean both public, but also in the private. Because remember, if somebody spends, say, 7 hours in a public hospital and spends 3 hours in a private hospital, this is extremely important, because it will not put more burden to the primary employer. The secondary employer is going to pay this person as he works. So you know, you earn as you work. So this is going to be, and there is a policy in the pipeline to that effect, where we are talking about dual practice. So you are rightfully employed in the public hospital, but you can as well go to the university and teach, and you become a professor. You can, and you paid for that. Right now, it is not yet implemented fully, but it is in the pipeline. There is at least, we can say there is a political will.
They should actually expedite that.
Yes.
Then.
And then when it comes to private, somebody can work at Sehashuka and work at King Faisal, or work at Sehashuka and work at legacy clinics, or any other private clinics. I'm sorry to use names. I hope no offense. So there are so many private clinics and hospitals that people actually go to and offer services, and they get paid for that. So that is also an incentive in a way.
Are you saying that currently only private practitioners can be able to do that, but public practitioners cannot do that?
No,
or none of them can do that?
No, currently it is done, because if you look at the law, the public law, or is it labor code? Yes, the labor code. The labor code permits that. But there was no instrument of implementation. So what we're talking about is that there are going to be ministerial orders or instructions to effect that, such that if I'm employed at Sehashuka or at Sehashube or at Rwanda Military Hospital, I could as well be free to talk to my boss and tell him, you know, on Tuesdays and Wednesday afternoon, I'll be at Hospital X. And that becomes very understandable. So I will not have any divided loyalty, because I know I'm there on Monday, I'm there on Wednesday, I'm there on Thursday and Friday, and on Tuesday I'm in my own private business, either personal or in those that have invested. Yes.
I think that's really timely, because when you look at a doctor does not treat individuals, but treats the public.
That's right.
So if, especially, you said, Daktari, how many specialists do we have?
We have close to 400.
Only 400
Yes,
across,
the 12 million.
12 million people.
Yes.
So to deny one of the 400 to be able to potentially access the 12 million people is actually a loss to the nation.
Indeed.
So I think that is something that is long overdue. But I want to take you on something you said earlier on around equipment being one of the incentives for medical practitioners. And sometimes it pains that you go to these leading public hospitals and they tell you that piece of equipment is not working, the other piece of equipment is waiting for maintenance. And sometimes I get the feeling that it has a lot to do with management of the hospital. That they have realized that they need an MRI, they need a CT scan, they need all these X-ray machines, but they have not thought about how this equipment is going to be maintained and cleaned on time and serviced on time and what have you. And sometimes I feel that it's probably because we have gotten our best doctors and taken them into administration, and therefore they don't know how to run hospitals. And they're better at running hospitals, and therefore the people who are running the hospitals do not know the importance of maintenance of the equipment. So the point I'm raising here is, do you feel the same frustration when there is equipment lying idle or underutilized at hospitals, Daktari?
Thank you so much for that intriguing question. You know, actually, the redundant equipment or having equipment that hasn't functioned for quite some time has got so many reasons. Maybe part of which can be blamed for governance and leadership. But let me assure you, if you look at the doctor that you would want, this doctor should be a leader in himself or herself. Should be a scholar, should be multi-purpose, should be a person that listens to advice, should be a person that when you have something challenging, you think out of the box. So in itself, having somebody as a director general of a teaching hospital, a big hospital, is in itself not a problem. But rather, why don't we have biomedical engineers today? Remember, this is a country that has been in existence for quite some time. But when you look in actual sense, Rwanda has barely lived for not more than 24 years. And this has got its own implication. You know, there are so many competing challenges and needs. When you say you want doctors, that becomes a priority. You want nurses, you want midwives, you want allied health professionals, such that the whole sector becomes... But then you forget that for somebody to perfectly, efficiently, effectively perform what he's supposed to do, you need some hard and soft facilities. So that has come in. Yes. I remember not more than 10 years ago, people were thinking that we can't have an MRI. But because of the strategic leadership of this country, they said, no, we must have an MRI. People thought we could not have linear accelerators, those machines that treat cancers. They said we should go back to the technology of 50 years ago. The strategic leadership of this country refused and said, no, we must have the latest technology. We have it, and it is going to help Rwandese. So what we can say is that maybe we may be having lots of competing needs, and therefore making prioritization becomes an issue. But I think there is always a will and there is always a breakthrough, because we have leadership that pushes. And with that, yes, we don't have biomedical engineers that have worked on these equipments because that is the stage of development we are at. But are we likely to continue like this for the next 10, 20 years? I don't think so. Because, you know, we have now IPRCs. And
what are IPRCs?
IPRCs are these polytechnic institutes. And these polytechnic institutes actually make students acquire skills and not this theoretical knowledge of being called an engineer when actually you can't handle any machine. When something goes wrong, you become handicapped. You say, but normally things go like, but we have a machine that needs work on. So right now, what are we doing to maintain the equipment that is in place? Unfortunately, it becomes a bit expensive, but worthwhile. Let's say, for instance, our MRI, the MRI, the only public MRI that is in the country. We ensure that it has got a platinum insurance. That's very hugely expensive for the country. But it is better than having this machine lying idle for years and years. Because right now, when anything goes bad, we call the manufacturers. They come, if it is a spare part, they fix it. If it is a software engineering problem, they sort it out. And they have got a limited time for intervention. If they don't, then we charge them. So this is, and it becomes unfortunately a bit expensive for the government, but at least we offer services. And you know, when you talked about the quality health care, you need to have a few things in perspective. Are you doing the right thing to the right person at the right time? And are you expecting positive outcomes out of this? So with that in mind, then you know that cost shouldn't be a problem, but rather quality and outcomes at this juncture.
And at this point, yes, I'd like to hear from the rest of the panelists, Brenna and Ephraim.
I wanted to go back to the issue of motivation, and I stand to be corrected. I know that part of the motivation package is that doctors are paid more depending on the number of patients that they see. Is that correct?
That is, it's not uniform.
Okay.
But there are places where you have doctors that have got basic salary and then they have over targets. So you say, doctor, if you are a surgeon, do these 50 major 3s, do 45 major 2s, do 80 major 1s. If you do 100 major 3s, then we shall give you a target for 50.
So for somebody like Ephraim who sells sugar for a living,
what is a major 1 and major 2?
Major 3, 2
No,
and 1.
I think that will divert us.
Sometimes I think actually major is like a rank in the army.
No, they will have to
very
pay
many of
school
our
fees.
specialists.
But were you done with your question?
No.
Yeah, just finish.
They will have to pay school fees to be taken into medical.
Thank you for defending me.
Just to finish my question, if that is happening somewhere, My concern is, doesn't that in a way compromise the quality of healthcare? Because, you know, these doctors are really looking at the numbers, because the numbers will in the end reward them.
Well, you know, it's so difficult. Medical training is indeed so vigorous to the extent that you're at work, you are on duty, and you offer yourself beyond the call. So, if say for instance I go to work at 6:30, I'm at work at 6:30, and I leave my place of work at 8:30 or 9. For God's sake, I'm a public servant. Say for instance I'm a public servant, and I'm supposed to work for
8 hours a day.
8 hours a day. I've worked for 16 hours. And if they call me at midnight, I will come. If they call me at 2, I will come. If they call me at 5, I will come. And I must be at work at 7. So there are things that doctor, if you are a doctor, and particularly if you are a specialist, there are things that you have gone beyond. So you cannot think of, no, I must, you know, it's not like digging. It's not like cutting trees. You can't, if you're going to see 100 patients, it must be in you that the first patient must receive the same care as the 100th. So if you're willing to see 100 patients and you still offer the same service, then go for it.
You know,
because it's a...
to you. Sorry to interrupt.
No, it's okay.
To you, that is what is expected. That is what is perfect on paper. But you're dealing with human beings. You know, human beings who need money for school fees, who need money. So that financial pressure is always there. So which takes me to the question of the association, you know, enforcing standards at work. Because in the end, I think that's what could ensure that even if that these are human beings, if you have a body that enforces standards, whatever happens, people will know that the quality of care will not be compromised. So how do you...
Yes,
you know,
that is extremely important. Actually, apart from what you asked me, I didn't come, or I didn't bring into perspective what actually the council does. The council essentially protects the population through the guidance of the profession. How do we guide the profession? We ensure that right away from the incubation phases. Incubation, for those of you who may not...
Who sell sugar.
Yes, who sell sugar. You must realize that medical school does not start from year 1. It starts from high school. Has this person done sciences that will equip him to be able to do 1, 2, 3? Then when you reach the university, the council assesses the curriculum. So when we assess the curriculum, we are essentially looking at the context under which this curriculum was designed. What are the outcomes? What are the competencies that this person from year 1 to year 6 will have at the end of this training? And are we training this person to be a curative doctor? Or are we training this doctor to be a community-based doctor? Or are we training this doctor to be a mix of the two? Because, remember, we have all the responsibilities from the promotional health to preventive health to curative health. Because you need to tell people about HIV. You need to tell people that unless you protect yourself, one will be pregnant, another one might contract a disease. Once this is done, then you know, once you can't buy that, avoid this, then if you do that, if you are pushed beyond, then prevent yourself using this. So that is preventive. You've heard about vaccinations, immunizations. Then you've heard the strides the country has taken, because there are so many things that this country is considered as #1 in terms of even having the scope of the immunization schemes. So these are essentially to prevent most of the diseases. But we know some people either didn't live in Rwanda or were born earlier before this was introduced, and therefore could have contracted some of these diseases. You've heard about hepatitis B and C. We know that hepatitis C is currently curable, of course with some effects. And the government under the leadership of His Excellency, we managed to negotiate for the medications that actually with rates more than 90%.
And that medication is very expensive.
No, it has been subsidized.
No, I mean globally speaking, it's a very expensive medicine.
If you compare this medication in Rwanda and the medication across the border, you will find it is like 1,000 times more.
Exactly.
So, but here, you get it at a very minimal cost. Even those in category 1 and 2 receive it for free.
But doctor, I'm going to hold you short there. We need to go for a break quickly. But I think you've given us very informative responses, and I think we've learned a lot just on the first half of this show. Ephraim, I'd like to hear more of you when we come back from the break. I know there's a lot you have. Stay tuned. We'll be back right after the break. Welcome back to The Square. We are discussing the quality of healthcare in Rwanda, and we're looking at how to retain doctors, how to improve the quality of doctors we have in this country, as well as we're also going to have a look at non-communicable diseases, which have an alarming rise in the country. But before we go to the non-communicable diseases with Dr. Rudakemwa, who's joining us this evening, I'd like to hear from Ephraim on some of the thoughts he had before we went to the break.
Yeah, so I've been sitting here quietly, listening to the doctor talk.
Uncharacteristically so.
I know, and because I was listening to the doctor talk, and everything he said sounded correct, in place, in order, and I'm like, but if that's the case, everything seems to be in order, then why aren't we seeing a much better healthcare system? And I think for me, where is that disconnect between, because I feel like what you shared with us seems like what is on paper and what has been agreed upon, but what is actually on the ground and what are some of the challenges? Where is that disconnect between having quality, having this quantity, and why we aren't seeing it? Because I'll give you one example. Diagnosis in Kigali is such a big challenge. People will tell you they go from one doctor to the next doctor to the next doctor, trying to find out what's wrong. Because they'll go to the first one, the person will say, oh, you take this. Then they go home for 2 weeks.
Get worse.
It gets worse. They go to another doctor. The doctor gives them something else, and you find that you keep doing that. And I know this is not an isolated case, and I think the doctor can explain why. But why is there that disconnect? And is it because? Yeah, I think you'll go ahead and explain. But why is there that disconnect?
No, I think you're right. What you need to understand is that when a patient comes to you or comes to a doctor with complaints, and I follow the protocol, I discuss with this patient, I listen to this patient, I ask this patient, I do physical examination, and it has got stages, then an impression comes into my mind that this is most likely 1, 2, 3. Then I request for what we call paraclinical examinations. Investigations, which include lab, radiology, and other investigative modalities. Now one wonders, if I am working alone in the clinic, one, my laboratory maybe is not to the standard. To the standard, when you talk about quality, you're talking about certain set of standards and guidelines. So it is not necessarily that all the clinics, all the hospitals may be at the certain standard. And so this means the results that will come out of variable settings may differ. And we talked about multidisciplinary practice. If you're working alone, or if we are working as 5 people, and I've seen this case and is very peculiar to me, and I ask her, she tells me, I think you need to think about this. You need to think about this. Then that increases the ability to make diagnosis of this patient, and therefore we are able to tackle the real problem. But the problem is that sometimes you find, I have been with this patient and I have considered her or him as my property. So this patient comes, we do this, we do this, we do this, go back, go this. And we have this tendency of some doctors making unnecessary prescriptions. And I'm sure you know that we have a world epidemic. It's a pandemic. of antibiotic resistance because people over-prescribe antibiotics and this becomes expensive for our countries, expensive for the world, and then actually becomes very dangerous for the patients because you cough, you have a viral infection, I give you antibiotics. You have this, you've seen moms.
Yes.
If you are a mother and you take your child to a doctor and the doctor doesn't prescribe 5 antibiotics, you want to go back.
Does that explain why sometimes doctors prescribe a certain medication that's not available in pharmacies?
Yes, that is unethical, but sometimes they do.
Just so that the mother won't get it.
Yes.
Prevent that.
Yes.
Yeah.
Wow.
So
Well, probably because they have shares in some of them.
not really. Not actually. Many doctors are allowed to have pharmacies.
Some doctors. You said not many doctors.
I
Some doctors are allowed to have shares in pharmacies.
What I meant is that actually there are standards for having pharmacies. You need to be a pharmacist, or you need to have a pharmacy in a hospital that employs pharmacists.
But coming back to the question at hand, so Ephraim, do you feel like your question has been answered in terms of the disconnect?
So I think for me, yes, I understand the disconnect. But then the question now, because we've talked about the role of the council, we've talked about these systems and these structures that are set to ensure that there's quality in the sector.
Yes.
What does the council do in cases where they realize that doctors are over-prescribing, or they're in a situation they are just misdiagnosing, where you say that the guy wants to monopolize his, or the doctor wants to monopolize the patient without consulting other doctors, even when they probably know that they have missed it?
No, you see, you're dealing with adults. And adult psychology dictates that you don't punish before you teach. You don't punish before you discuss.
Okay.
And tell him, you know, Emmanuel, I think what you're doing is not right. Let's work like this. Because, you know, if you look at any justice system, because the council, as a regulator, you have to be fair and just in whatever you're doing. So that implies that when I have a doctor that somebody has talked about, but this person does not want to put it down, because you can't investigate from air. If you have had this kind of mistreatment, or you think you have been misdiagnosed, or you think there was a malpractice, you need to come up and tell the council. You need to come up and tell the Ministry of Health. You need to come up and tell maybe CID. Then the investigation is launched. But sometimes you know it, and you have it talked on the tables, talked in the bars, and you cannot have a basis.
But doctor,
to do something.
Wouldn't it be better if you as the council self-regulated?
Yes.
And I'm saying this because now when you talk about that whole thing of you cannot punish before X, at the end of the day, it's at the expense of somebody.
It's life on the line.
It's life on the line. So the question is, if you guys amongst yourselves as the council, why don't you have systems internally that you guys can hold each other accountable?
No, we do.
You do.
So
then the question is, then how, that's what I was asking, what systems do you guys have in place to ensure that it doesn't happen, or at least it holds?
Let me just.
But can you answer that very quickly?
Yes,
because I'd like us to move on to the next part of the.
We have a code of conduct, which is like a Bible to a doctor. 2, we have guidelines and standards. You know when to do what. And when you deviate from that, then you can be charged with malpractice. And we have actually deregistered some doctors. We have punished some doctors for 6 months, for 3 months, with suspension. And this takes place. So we have internal control system that indeed functions.
And you're happy with it? You believe it's effective?
Of course, it can always be improved. It can always be improved. It can always be improved. Remember, with standards and guidelines, they're actually frameworks. And so, and the human head and human heart and the human mind is much stronger. I mean, I can always dodge you. But what you need to do is to teach and see if there can be a mindset change.
So I would like to now take us to this issue of non-communicable diseases. And here I'm talking about cardiovascular disease, cancers, diabetes, and they're on the rise in this country. For me personally, you know, I had to educate myself about this. I really thought NCDs were a sign of a prosperous country. You know, people who are overweight, people who are pressured because of, you know, things that we hear of in more advanced nations. Why is this happening in Rwanda? And what are interventions being done to curb this?
Thank you very much. That is a huge, brilliant question. You need to understand that the non-communicable diseases is actually a global burden. It's not a Rwanda's burden. And that does not, therefore, make it any easier to us. But it just shows that us being the part of the global world, then we need to do more. And at a promotional level, at a preventive level, and at a curative level. Yes, you've talked about cardiovascular diseases. You've talked about cardiometabolic syndromes. You've talked about diabetes, hypertension. You've talked about, we talk about cancers. The World Health Organization today estimates that by 2030, we might have 70% of the population dying from non-communicable diseases as opposed to dying from HIV, from malaria, from TB, all combined. So this is a real threat to the world population. So indeed, what can a country like ours do? A country like ours actually does what the rest of the countries have done, because so what we have today is that there has to be a national communicable disease plan. And this control plan has got specific interventions, both at promotional, at preventive, and at curative level. So indeed, when somebody has a child of 10 years who weighs 60 kilograms, he feels my child is, this is a child of the boss. That is, so you need to have a mindset change and understand what you need to give to your child. That has to change significantly, because kids also have these diseases. So I think there are so many interventions, both at promotional health, at promotional level, where they're teaching people what to eat, doing sports. You've seen,
I think Car-Free Day.
Yes, Car-Free Day, and actually advising people to do exercises, requesting people not to sit in the same place for so long, eating moderately and exercising more. So those are some of the things. And two, the government has put in place some equipment to help us diagnose. Actually, you may have some of these conditions, and because you don't have
the tools,
biochemical measurements, then you lose.
Actually, if you don't mind me adding to that, there is this common belief that the reason why it seems like there's a rise in NCDs, or at least, there's a rise in NCDs, is because the depth of our health sector, or at least the knowledge of these diseases, has been a bit shallow.
That's right.
So as we have advanced with education, we are now the doctors are now more equipped to diagnose and say, oh, actually this illness is X, and that's why there's been a rise. And
exactly.
So you agree that that's actually...
No, that is a fact. Okay. And in those Car-Free days, you find people coming for blood pressure checks, glucose checks, and all those things have actually yielded potential results for people being treated without having symptoms. Because remember, you can have a silent disease, but when it manifests, it manifests when it is actually very advanced and it kills. You know, we are talking about breast cancer. It's one of the major causes of morbidity, or causes of being sick, and actually cause of mortality for people to die. But we know once breast cancer is gotten at a very early age, at a very early stage, I beg your pardon, it gets cured completely. Now, as I was talking about the equipment that are being bought, the diagnostic tools, the treatment tools, I've told you about the linear accelerators at Rwanda Military Hospital, which you need to make a lot of documentation on, such that people know.
Absolutely, people need to know these things.
People have been thinking that when you have cancer, you go to Uganda. And Uganda has, I'm sorry to use that word, but they have been having the very old systems that actually, if you want to treat the eye, you end up treating the whole head. And people are happy because they didn't know that actually maybe they were contributing to their ill health in a way. So we need to understand that, yes, we still need more, but I think we are in the right direction. Of course,
and Doctor, I'd like to take us to a Twitter feed because we're running out of time. And some of the Twitter mentions actually talk about NCDs. And this particular person, if we can just read it from the screen, says that, and this is Simba Kaliop, who actually says that, I have always been asking this question but none to answer. The data on NCDs are mainly from hospitals, I mean HMIS. I would suggest a national fact sheet to inform all interventions. Another aspect is diagnosis. There might be false positives. So he is saying that with NCDs, and this is what Ephraim also mentioned, it's the advent of medical practicing that is leading us to these particular insights. But what do you think of his tweet on having a national fact sheet?
That is extremely important. I think Dr. Simba is right. I know him. Yes, you cannot plan, you cannot design interventions without proper statistics. And what I think we have embarked as part of the national control plan, we are, I mean, the RBC and the Ministry of Health are putting in place registers. And these registers essentially are going to be a source of information which will be a huge contributor to facts and figures. It's extremely important to understand that you cannot put a national control plan for disease X when actually you don't have it. So that one becomes an imperative step to make sure that when you're talking about breast cancers and you know you have these, your interventions will be, you'll have value for money. And so that is in the pipeline. Indeed, we don't have yet national checked fact sheets, but the registers are being put in place. We are going, I mean, we've talked about trauma registers, we've talked about hypertensive case registers, we're talking about cancer registers, and there is actually a WHO recommendation or instruction informing all member states to have cancer registries, because they're essentially the basis for planning for any intervention in any country. Short of it, you would go and invest billions in heavy equipment when in actual sense you didn't need it.
And
so talking of,
they're right.
Just very quickly to the next tweet before we go to the next part of the conversation. This is also on to do with NCDs, and it seems people on social media are actually concerned with this particular topic. The food that we eat is very poor in essential nutrients, and sedentary might be the reason for NCD rise. Remember the metabolic syndrome, Genesis in life. Let us teach people what to eat and restore their life by using some food supplements. I think the food in Rwanda is healthy. I don't think there's an increase in the sort of
relatively speaking,
foods that
yes.
cause NCDs.
Relatively speaking, remember.
I'm thinking of ibijumba, that's boiled,
those are very good, but you know, remember your kid or yourself may not be eating those very
Pringles.
So you have to go.
But the majority of population don't eat.
Right.
So the majority of the population,
Yes,
this
yes,
NCD alarming trend, and again, I stand to be corrected and more informed. I feel like it's a certain number, you know, that's based in urban areas and lifestyles. But the majority of Rwandans who live in rural areas.
It's an affordability
problem. We had a serious issue. We had a serious issue around GMOs.
Yes. Okay.
In our country, and these are things that people don't know. Like the ibijumba that is considered healthy when it's on your table.
Yeah.
When you trace back even the seeds that went into that particular product, it's very questionable.
Yeah.
So these are things that I know, like even the Ministry of Agriculture has been going back and forth with I don't know if it's with the council, but I know there has been a lot of, us as traders have been told, certain products are allowed to be GMO, some can't, you have to pick and choose. So that stuff is, I think, if you trace the food in itself, it has a source. So
we're not safe?
I wouldn't say we're not safe.
I think that's why the government has put in place a regulator for that, the National Drug Authority.
Yeah.
Actually, it's Foods and Drug Authority. So that one is going to be equipped to be able to detect any variations from the norm. And right now, as we're saying, we just think that whatever has been brought, the fertilizers, you know, from the time the fertilizers have been put in the soil, we haven't been able to assess qualitatively and quantitatively I know RAB has had some tools to be able to measure that. But I believe that the Food and Drug Authority is going to be more equipped in terms of instruments of measurements to the extent that we may be able to identify and determine how much our people indeed consume. Yeah, we may be deceiving ourselves that there are things, but remember, there are things that we don't know, and there are things that we know. So those at least that we know, we can concentrate on them and then work on those and then declare.
Very quickly for my panelists, last time I had to manage time, so I'm trying to do better tonight. Last time you guys were an unruly bunch, but it's been a great conversation. We're coming to the end of the show. And of course, I'd love it, if we end the show with closing remarks. If you can make them very quick, especially you, Charles.
Mine is very, very quick.
Charles, Bern, and Ephraim, and obviously ending with you, Doctor.
Mine is very quick. Obviously, you'll appreciate, Doctor, that Diana will harass us because these things of health affect our lives, and therefore they'll be very personal to us. I want to understand the extent to which the Medical Council is plugging into the entire nucleus of where Rwanda wants to go. And I'll point myself towards two specific areas. One is the quality of service that you give to the patients. By the time I get to the doctor, if it is an emergency, and we do have a very, very big problem with the response time. But even worse still, there is no single hospital in this country, whether private or public, that respects appointments. And if we are going to talk about MICE, which I'm sure includes medical tourism, we're not doing anything about it. So what's the extent to which the council is cautious about some of these things that really matter so much in terms of not only people's lives, but the whole agenda of the government? Yeah.
And before you answer that in your closing remarks, I'd like you to combine that. I'd like to also hear from you, Brenna. I hope it's not a question. I hope you have conclusive remarks, because we are left with exactly 2 minutes, and I'd like to end the show on a conclusive note.
Yeah, just to underscore what he mentioned, which I think speaks to patient rights. Yes. Because right now we continue to have doctors who are experts in everything, but we know that as a patient, you really, really have the most information about your body, and it would help if doctors at least take time to respect your right as a patient, to consult you, to ask you questions, to even explain to you why they are doing certain things to you, why they are prescribing certain medications. I think that is something that has to be
patient rights.
Yes, patient rights.
Absolutely.
I think in our healthcare.
Ephraim, conclusive remarks, please.
For around NCDs and quality of professional healthcare, the capacity within the sector, I'm okay. I think the topic I'm really curious to hear the doctor talk about, but maybe not today, is about the sustainability of Mituweli. But that's
I think Mutuelle de Santé universal coverage is a topic on its own that deserves the weight of its own. And if you could actually have
medical
officials,
insurance is a big gap, yes.
Yeah, from ministry officials. Your conclusive remarks, if you can tackle this in 1 minute.
Thank you so much. Thank you, Diana and the team and RBA. We are talking about healthcare quality, which is essentially the kind of services that we offer to our people, to the people that come to us, whom we have a social contract with, to the extent that this care and service that we must give should be safe, should be effective, should be timely, should be efficient and equitable. We have tools in place to help us be accountable, be checked. We have patient rights. And patient rights are pinned everywhere you go in every hospital, up to the health centers. So patient rights, indeed, we need to do some more work on teaching patients what their rights are. But as we talk about the patient rights, we should also talk about doctors' rights, healthcare professionals' rights. And what we can say is that we always, and we advise, and actually it's instructional, that before you do anything to a patient, discuss, agree, and the patient has a right to refuse or accept. We have education tools. Those education tools are applied and should not be applied in one place and not the other. They should be uniformly applied. Are appointments respected or not respected? The hospital I work for tries to respect appointments.
Which one is that?
I don't want to say it.
Because it doesn't respect.
Yes.
Please.
What I'm saying, sorry to delay you.
Yes.
I'm saying, yes, we also don't respect appointments as patients. So I think there is work to do on both parties.
Sides, yeah.
And I believe, yes, that is going to be an imperative thing to do, especially if we are to act as a hub for medical tourism.
Thank you very much. I honestly think we need, dealing with RBA, maybe an extra 15 minutes on this show, because the conversation just keeps on going and going. Thank you very much, Doctor, for honoring us with your honoring our invitation. Charles, Ephraim, and Brenna, always a pleasure to have you guys on board. We've been discussing healthcare, the importance of looking at the human resources in the healthcare system, the importance of targeting NCDs and looking at how we can actually decrease the increase of this disease that's in the country. Please follow us on Twitter, The Square Rwanda, The Square RW, for more information. We keep the conversation going until each show, after each show, until the next show. It's been a pleasure having all of you here tonight. Please be with us until next week. Have a good evening.